Hello everybody and welcome to today's webinar, Near-Infrared Fluorescent Imaging of Lymphatic Disorders. Before we get started, I would like to go over a few items so you know how to participate in today's event. You may have joined the presentation listening using your computer speaker system by default. If you would prefer to join over the telephone, just select phone call in the audio pane and the dial-in information will be displayed for you. You will have the opportunity to submit text questions to today's presenter by typing your questions into the questions pane, which is found at the bottom of your attendee control panel. You can send your questions in at any time during the presentation and we'll collect them and address them during the Q&A session at the end of today's presentation. It's my great pleasure to introduce Dr. Miguel Amore. Dr. Amore is the General and Vascular Surgeon, second head of Phebology and Lymphology unit, the Cardiovascular Surgery Division of the Hospital Militar Central in Buenos Aires, Argentina, and is a staff physician at the unit of Phebology and Lymphology, the Foundation Favaloro. He is the elected president of the International Society of Lymphology and a member of the Executive Committee of the European Society of Lymphology and president of the Buenos Aires Society of Phebology and Lymphology. Dr. Amore, over to you.
Hi everybody, and thank you for this kind introduction. We are working at the military hospital with an alarm situation about the coronavirus, so I will try to speak about the near-infrared fluorescent imaging of the lymphatic disorders. Okay, we must start now. Just no financial disclosure. This is the summary of the presentation of this presentation, and the aim is to show how the fluorescent images can help to understand more about the physiopathological changes of the lymphatic system and how it helps us to treat lymphatic disorders. And regarding the evolution of the visualization methods, you can see a picture here. I don't know if you can see here a picture of on oil lymphography, and these methods had long been the choice for imaging the lymphatic system described by John Kimon in the 60s. And today we perform it in some special cases. And this method declines and the introduction of the lymphoscintigraphy. You can see here a picture of a lymphoscintigraphy of 1975. A patient gave me some time ago, and the evolution of this method, the lymphoscintigraphy, and with high resolution. You can see here the clinical picture and the correspondent of lymphoscintigraphy in this case of primary lymphedema, and you can see all of this lymphography was made by Dr. Sarlenga here in another hospital, Rofo Hospital, if an oncology hospital. And you can see here in primary lymphedema, you can appreciate the dermal backflow here and the lymph node at the level of the knee. And this is the clinical picture of chylous reflux with the primary lymphedema, and you can see the dermal backflow and the connection with the high resolution of this type of lymphoscintigraphy today. The connection with the instancing too. It's another case of primary lymphedema too, with the correspondent of the lymphoscintigraphy. With evolution, the lymphoscintigraphy can combine actually with the SPECT-CT. This is a courtesy of Dr. Sarlenga too. This is an example of the melanoma of the skin here. And you can see two sentinel node here in the axilla and in the groin. And when you combine with the SPECT-CT, can observe the retroperitoneal node too. It's so interesting, and actually we can perform MR lymphography with or without contrast too. with the advancement of the science, the development of the near-infrared images, actually we can find some device using this technology to see vein and lymphatic. As you can see here, the example, to see the superficial vein, the corresponding anatomy specimen. You can see the superficial vein too. And with the use of near-infrared vein finder, you can find this type of images. It's so interesting. It's the same with the lymphatic system. It's an anatomical specimen. And when you add the near-infrared fluorescent images, you can see in vivo this type of images. It's so interesting. All methods are complementary, and we decide which we choose depending on what we need to evaluate. It's important because it's important to remark that all methods are complementary. And the ICG lymphography, it's very interesting, and it's in real time with that radiation, and we can make it at the office in a few minutes. And for me, it's only a personal concept, made a revolution. We can detect early changes of the lymphatic vessel after a damage. You can see here a scar here, and a scar after stripping of the Grace venous vein for myocardial revascularization, and of course the secondary lymphedema. And what happened with the lymphatic system, instead of a linear pattern, we can appreciate the dermal backflow, the dermal lymphatic as a dermal backflow, and the stop at the level of the scar. As you can see here, the dermal backflow. The other things to remark about this method is to do it only by physiological condition. That means with a high pressure of the tissue, the dye can move. We must to reduce the edema at first. This is an example of a lymphedema of the hand, and you can see the stagnant of the dye. ICG lymphography was first reported in 2011 for evaluation of lymphedema. In 2011, the Japanese group described different patterns of dermal backflow. This pattern changed according to the pathophysiology changes of the lymph flow and lymphatic vessels, changed to become more sclerotic with less lymph flow. They classify into two large groups, as you can see here. Linear pattern, it's normal pattern, as you can see here at first in the normal legs. It's a linear pattern. And dermal backflow pattern. As lymphedema progressed, the pattern changed from the splash here, to the stardust, and eventually to diffuse. This is the latest stage of the lymphedema. We can appreciate the diffuse pattern. For me, the best use of this technology is to stage 0 of lymphedema to detect early changes. What is the significance of stage 0? Is without any sign of the edema. Any type of edema, any sign of the edema is the stage 0. And this is the best example for me. As you can see here, a patient with axillary lymph node dissection after a melanoma. As you can see here, the patient with any sign of edema here. And we follow the progression of the changes with the ICG at 5 days after surgery. We can appreciate a stop of the dye at the axilla, as you can see here, the stop of the dye of axilla, and a little area near the scar of dermal backflow with collateral circulation to the contralateral axilla, as you can see here, a linear pattern, and a linear pattern here at the level of the hand. After 30 days after surgery, we observe a linear pattern, but inside, as you can see here in this picture, and inside the vessel, we can appreciate more fluorescent in separate points. As you can see, different points here with more fluorescent, more luminescent area in separate points. And it's an accumulation of the dye. This is an indirect sign of the disturbance of the lymphatic motricity. And here the area of dermal backflow became more bigger with collateral circulation at, as you can see here, 90 days post after the surgery, and more bigger and more collateral circulation too. It's the same, more collateral circulation to the contralateral axilla, but now at the 90 days after the surgery, the collateral circulation is from the dorsum. And for that reason, we can stimulate the derivative pathway using this type of method, the taping. It's so interesting because we can test with the fluorescent images the useful of this type of method, the taping. It's a complementary method to the rehabilitation of the patient with lymphedema. It's very interesting. We have a lot of patients with test with the fluorescent images, and Dr. Marco Vecchio and Paola Shanes help us to do this method. They work with Kenzo Case, the pioneer of the technique. And this is another technique, another patient with the stage 0 without any sign of edema. In this young lady with breast cancer and axillary lymph node dissection, and she came with us. Asking about the pain of the pain of the shoulder and an area near the shoulder here, and we perform the ICG and we observe a linear pattern at the distal area. As you can see here, at the level of the hands, you can appreciate the linear pattern, and at the forearm, as you can see, diffuse pattern, and near the pain area, at the pain area too, we can observe the dermal backflow and with the diffuse pattern here. As you can see, the same diffuse pattern near the scar with collateral pathway to the contralateral axilla, trying to compensate the lymphatic hypertension. And this picture is to understand how we can help this type of patient with this method to stimulate the contralateral pathway using taping too, as you can see in the picture. And this is an advanced stage 2 of the International Society of Lymphology classification of lymphedema, the peripheral lymphedema, and you can see a diffuse pattern at the level of the hands with the stardust pattern at the level of the arm, and with interbreast derivative pathway. It's so interesting in interesting case in advanced stages. This is an stage 02 with a secondary lymphedema after axillary lipoma resection. We can compare the lymphoscintigraphy. As you can see, the images of the lymphoscintigraphy without any type of dermal backflow. But when we develop the ICG lymphography, we appreciate the dermal backflow at the level of the hand here, and a diffuse pattern at the forearm, and collateral circulation at the level of the neck here. It's so interesting because we can find any types of reflux, any type of dermal backflow with the lymph when we perform the lymphoscintigraphy, and we perform with the ICG lymphography. We can detect different patterns, and the collateral circulation, it's more sensitive method to detect this type at the early stage 2. And it's very, very interesting. And this is an interesting case of a young lady with psoriasis arthritis, and they use in immunosuppression, and the development of lymphedema, but only at the dorsum of the left hands, as you can see here, the dorsum of the left hands. And she have some pattern. She have the same patterns, and the strength of the situation is because she have the same pattern on the both hands. When we use the ICG, but the clinical sign of lymphedema, it's only on the left, the dorsum of the left hands. As you can see, in the right hand we don't have any signs, any type of edema. And when we develop the ICG, of course, at the dorsum, it's corresponding the images, because you can appreciate the diffuse pattern at the dorsum of the hand. But here, with any type of edema, have the same patterns. Not only at the dorsum, because it's the same pattern, at the palm of the hands have a lymphatic hypertension too. As you can see here, it's so interesting. We don't know if the use of the inflammation of the secondary lymphedema was made by the inflammation of the arthritis psoriasis, or when the patient used for a long time the suppression. And regarding the pressure, lymph circulation, and lymphedema, this concept was studied for a long time with Professor Olszewski from Poland. This is an interesting concept because in the rehabilitation of our patient, we use a lot of pressure. Some schools develop or use it a lot of pressure therapy, and the paradigm is of the pressure therapy is not to increase the pressure more than 40 millimeters of mercury, because have a great risk to damage the lymphatic vessel. And we test this patient with secondary lymphedema with fibrosis of the tissue using a blood pressure cuff, and we test the pressure to move the flow, and with 40 millimeters of mercury, we can't move anything. Only when we increase the pressure to 80 millimeters of mercury. It's so interesting because we can test with the cuff, insufflate the cuff, and you can see the fluorescence of the movement of the flow when increase the 80 millimeters of mercury. It's so interesting to see with this method. And what happened, how we can use the fluorescent images in a lymphatic malformation. In case of lymphatic malformation, this is interesting patient, because we use the fluorescent images in case of intrapelvic lymphangioma, and we can combine the images of the lymphoscintigraphy. And of course, you can see the lymphoscintigraphy. This is the patient with the intrapelvic, and you can see here the picture with the intrapelvic lymphangioma, and can this curve can move to the level of the groin. As you can see, we can compare the images of the lymphoscintigraphy. As you can see, the lymphoscintigraphy can detect the lymphangioma near the groin, and of course, not in the pelvic too. And when we perform, here we drain the lymphangioma at the level of the groin. And when we perform, as you can compare here, the lymphoscintigraphy, and when we perform the ICG lymphography, we can detect the lymphangioma at the level of the groin. It's so interesting. Of course, the intrapelvic, we can detect it because it's so deep, but the superficial area at the groin, we can detect it two type of cysts with the connection, as you can see at the arrow here, the green arrow here, and the patient, we can draw the lymphangioma at the level of the groin. We can perform cyst venous surgery too, but it's not the topic of the presentation. But we can help us to identify the type of the lymphatic malformation. This is another case on lymphangiomatosis. It's so interesting, the soft tissue here at the dorsum and the anterior part too, and we inject in one of the more biggest cysts here, as you can see in this slide, and we inject too in a little vesicle. We perform with Fernando Deep. He helped us to develop the technique. And here you can withdraw the malformation in the skin. As you can see here, the big cyst and the connection to the axilla and the connection to the groin. It's so interesting and help us to develop the surgery to resect the big cyst here. And you can see with fluorescent images the connection, the big cyst here, and the connection between the axilla and the groin. As you can see here, the anterior part of the connection with this type of malformation. Just a minute. In case of another type of malformation, the Klippel-Trenaunay syndrome, it's a combined malformation, venous malformation, a capillary malformation, and lymphatic malformation. With the use of ICG, we can observe the commitment of the lymphatic system. As you can see here, the patient with the hemorrhagic lymphangiectasia, and we can detect the lymphangiectasia with the ICG here at this level. It's so interesting to know more about the commitment of the lymphatic system in this type of malformation, a combined malformation. And just it's very interesting because this is a different malformation, a combined malformation with primary lymphedema, peripheral lymphedema, with protein losing enteropathy. It's a intestinal lymphangiectasia. It's a Baldman disease. In some cases, combined with primary Baldman disease, was described by Baldman in 1962. See the lymphedema of this young lady who developed the disease at the age of 25 years old. And you can see the peripheral lymphedema. We developed the capsule endoscopy, and you can see the lymphangiectasia here. It's so interesting, and how the fluorescent images can help in the diagnosis and therapeutic of this type of patient. And we develop with the unit of gastroenterology of this hospital with the stomach injection of the ICG at the preoperative endoscopy, and we add ICG with cream, and the patient eats 12 hours before the surgery at the preoperative by oral. Of course, the patient eats, they mix it with cream with the ICG. And intraoperative, we use a nasogastric tube to infuse the ICG with cream too. And we use fluorescent guided laparoscopic surgery. And it's interesting to know more about this type of images. As you can see here, the just a moment. Lipogranulomatous lymphangitis is an obstruction of the lymph vessel at the intestine. As you can see, the superficial lymphatic vessel are obstructed, and inflammation, obstruction, and lymphangiectasia. It's a lipid material inside the lymphatic vessel and become the obstruction of this type of vessel. It's interesting because we add fluorescence and the dye can enter inside the vessel because have a obstruction, a thrombosis with a lipid material. It's also interesting, as you can see here, the chylosascites, and we perform the fluorescence images. As you can see, the chylosascites here, the chylous leaks. And the same without fluorescent images, of course. As you can see, the lipid material inside the vessel with obstruction, the exudative area with fibrina here, and it's very interesting to see the lymph vessel at the superficial intestine. As you can see, the obstruct, and we perform with the fluorescent images. The dye can enter because it's a thrombosis of the lymphatic vessels, and it's very interesting to see how it's in the lymphatic of this area, and how we can help this patient with this technology. As you can see, the fluorescent images of the chylous leaks here, and when we perform the fluorescent images here, it's the same images with and without fluorescent. And how we can help this patient. Of course, this is a malformation. This is a very difficult situation to treat of this patient. It's a combined malformation with a digestive malformation with a peripheral lymphedema, and we only try to help this patient with a palliative treatment. And we perform in the same time of surgery an augmented lymphatic transplant. As you can see here, for that reason we inject previously by endoscopy stomach injection. And you can see here a little piece of the augmentum to transplant. As with microsurgery, we perform the transplant to the both sides, of course, and you can see the patient after and before. Of course, the patient continue with the dietary treatment because it's a malformation too, and we don't correct the malformation, just only to help with the dietary treatment to reduce the kilos leak, and we help the patient with the treatment of peripheral lymphedema. The patient continue with the physical treatment, of course, and non-elastic garment too, as you can see here. This is one of the last cases of lymph chylous leak after a nephrectomy. It's very interesting patient because he came with us asking about how to interrupt the leaks of kilo, and we perform here, as you can see. We perform a percutaneous lymphography by ultrasound. We detect the lymph node here, and we inject a lipidol here, and it's an oil lymphography. We as I comment at the beginning, we develop the oil lymphography in special cases, in select cases. For that reason, as you can see here, we perform this type of percutaneous lymphography. We detect the lymph node by ultrasound, and we inject percutaneous needle inside the lymph node, and we inject lipidol, and we get this type of images. As you can see, the stop here, the dye continue with the lymph vessel and retroperitoneal lymph vessel here, and the stop here. And the leaks are at the cavity. As you can see, the dye inside the cavity. It's a free inside the cavity, and we detect the level of the leaks here. And we perform this type of procedure. We combine the fluorescent images, and like the same patient, we combine the ICG with cream, mix it with the cream, and use the nasogastric tube intraoperative. And we perform the same technique, the percutaneous lymphography, but not with a lipidol. We use the ICG intraoperative, and we perform the lymphography with the ICG to detect the fluorescent dye inside the cavity. And for that reason, we combine this technique with fluorescent dye laparoscopic surgery. As you can see, a little, just a moment, here, a little video because it's too long, but here we can do it again. You can see here the leaks with fluorescent images. Here is to remember the anatomy at the level of the leaks. It's in here. It's anatomy specimen of the thoracic duct. As you can see, the two lumbar trunk and the level, the dye enter because the lumbar trunks come follow the flow of the lymph node at the ground, and we inject the ICG at the ground level, and the dye come from here and combined with the trunk, gastrointestinal trunk at the retroperitoneal area. And this is the level of the leaks near here, and just to remember the anatomy. Okay, as you can see here, with and without fluorescent images, the lymphatic vessel here, we detect the leaks of the lymph vessel of the leaks with the fluorescent. As you can see, the same color. It's impossible to detect the lymph vessel without fluorescence. It's also interesting because we clip this when they stop the leakage immediately of the surgery, after surgery. Just to final take a home message, a near-infrared fluorescence is useful to understand early physiopathological changes of the lymphatic system after a primary or secondary damage. The early lymphatic disease is treated, the more that can be done to prevent its progression. And near-infrared fluorescence can detect chylous or lymph leaks using an open surgery or laparoscopic surgery. It's depend of the anatomy concept. And finally, in some cases, the surgery can stabilize the lymph circulation as a palliative treatment. And I would like to thanks to all people here. Fernando Deep is my mentor in the ICG technology, the fluorescent imaging. Raul Rosendam from Cleveland Clinic 2, Sandra Jerez of the military, the team of my unit in the hospital, Dr. Bengoa, Marco Vecchio, Castro Salvia, Paola Giannis, Florence Secchi, Oscar Gural from Favaloro Foundation, my other place of work, and the other of my mentor is Professor Papendiek, and Maria Gomez, the assistant of Angiopedia Foundation. Thank you very much, and I think that we must move to question and answer.
Thank you so much for a wonderful presentation, and we have got lots of questions in. Our first question that we have today, a question is saying, could you comment on where and how much ICG you need to inject to visualize the thoracic duct?
Yes, it's depends, but usually to see the thoracic duct maybe just it's depend the type of problem or malformation or the damage of the lymphatic system. If we perform by in every web space, we usually use 0.5 milliliter of ICG in every web space, And if we perform intranodal lymphography with the ICG, it's depend, but usually with the same with the double of doses of that we use at the level of the feet. Usually in 5 to 10 minutes, we can observe the fluorescent images at the level of the thoracic duct.
Thank you very much. And another question here. Could you please comment on the use of the lymphatic venous bypass in severe lymphedema in a severely obese subject?
The question is about the surgery, the lymphatic venous anastomosis.
Yes, correct.
Yes, I try to don't explain more about that because Professor Macià from Barcelona have the concept of the use of fluorescent imaging in the surgery, but usually we can. It's so interesting to see inside the surgery. And we use a lot of the fluorescent imaging to detect the superficial lymphatic, and to know more about this type of the type of physiology of this type of vessel to detect and to help us to develop the anastomosis. Because as I say at the beginning, we can detect a different type of lymphatic vessel. It depends the progression of lymphedema. Of course, for me, the best, and for all, the best patient to develop the anastomosis it's in the early stages, and for that reason we must to do it in a very early stages. In some center around the world, like in Italy, the unit of Dr. Campisi and Dr. Boccardo develop inside the surgery after lymphadenectomy, and it's so interesting to use it in early stages of lymphedema. And we can see the pattern of the patency of the lymphatic venous anastomosis. But
Thank you very much.
the aim of the presentation, it's not to develop in lymphedema surgery. Just I touch a little things about the lymphatic disorder, the lymphatic malformation.
Thank you very much. Another question, in some of your earlier slides, you were using a handheld camera, and we've had a couple of questions saying that they're curious which handheld IC...
What camera?
You were using a handheld camera,
Yes.
and they were wondering what type of handheld camera you were using in those images, because they've been having trouble sourcing one that is affordable.
Yes, the type of the camera, of the hand camera, it's the ICG Flow. It's the camera that we use it in the unit. It's very easy to do it, and very easy to manage the camera. The name is ICG Flow. It's if you ask about this, it's the ICG Flow. Is the camera of the unit.
Thank you for that clarification. A question here saying, what background levels of ambient light are necessary?
Sorry, it's about the ambient. Sorry.
They're saying what background levels of ambient light are necessary when...
Okay, yes. It's we develop in an office without any type of light, because we need the dark to develop the type of ICG lymphography. When you have a little light, the sensitive of the camera, it's not good. We must to develop in the dark in the dark area, in the dark office, to develop to more sensitive method or more sensitive images. To get the better images, you must to dark the ambient.
Thank you very much. And a question here, how do you envisage the future of this technology?
As I mentioned at the beginning, I think that it's a revolution it's a revolution of this technique to apply to the lymphatic system, because I come from the anatomy, and I'm professor of anatomy at the Buenos Aires University, and I have a research lab of the lymphatic anatomy. And for me, when we applied the ICG, is the same. You can see the same finding of the specimen. It's so interesting to see the lymphatic vessel with the ICG camera, with the ICG flow in real time, and you can appreciate. I can show a lot of video, but you can appreciate when you use the ICG flow, the flow, the movement of the lymph. It's, for me, it's exciting because you can see the same, that the specimen, the lymph vessel, but we add, when you use a live specimen or live patient, of course, the patient, we see the movement of the lymph. It's for me, it's very interesting. And we add the technology with other malformation or the lymphedema. It's in normal condition, you can see the flow inside the lymph vessel. It's so interesting. Of course, it's the superficial lymph vessel, but the lymphedema, it's regarding the damage of the superficial vein, the superficial lymphatic vessel. It's so interesting. I think that for the future, it's we must to do it. All physicians who work with lymphedema, we must to do it this type of procedure. I think that it's the best. Of course, we usually add other method like lymphoscintigraphy, because all of my patients have a lymphoscintigraphy too, because we combine the method to know more about it, depending the patient. But for me, it's more sensitive for the superficial lymphatic vessel, the ICG technology, and then near infrared fluorescent images. But we can combine the technique. For me, it's the best. But we usually add other method, magnetic resonance to lymphography, and oil lymphography too. In special cases, lymphoscintigraphy. We work a lot with lymphoscintigraphy. We can see the deep lymphatic system, and more about the physiopathological changes too. But it's more deeper. And only can see with the lymphoscintigraphy only one type of reflex of the dermal backflow. And when we use the ICG, the near infrared fluorescent images, you can represent different type of dermal backflow. And it's dependent the progression of lymphedema. For that reason, I think that it's more sensitive to detect the early changes of the lymphatic system.
Thank you very much. And we've had a couple of questions in about the presentation. We are recording today's session, and that will be shared with all of our attendants after the webinar. And being conscious of time, we have got lots of questions that we haven't had time to get to, but we'll just take one more question here. We have a question here from a surgical oncologist in the Panama Republic. And they're asking, how could they implement the technology in their country?
It's just we work for a long time trying to develop inside our hospital. We, as I mentioned, Fernando Deep, who now is the president of the Fluorescent Guide Surgery Society, and help us to develop the technique to develop the ICG lymphography. And now we can work together, and Fernando was my mentor in this technique. But usually it's maybe it's expensive at the beginning, but the results of the method, it's so interesting, and I think that it's important to give an opportunity to do it. The company help the hospital to develop the technology, and we combine the use of hand camera in the unit of Phebology and Lymphology units in the hospital, and combine with the inside the surgery with the laparoscopic surgery too, with the use of fluorescent images. It's so expensive, but the result, I think that in the future, all of unit of a surgical unit, we must to develop this type of technique to reduce the risk of patient, and of course the fluorescent imaging can apply to other type of surgery, and all of the unit can implement the fluorescent imaging. I think that it's the future to do it.
Thank you so much, and thank you so much for your presentation, and thank you to all of our audience for joining us. We have captured all of the questions, so we will be able to follow up with you after the webinar. Once you leave the webinar today, you will receive a survey on the presentation, so we would be grateful if you could keep your browser window open for a couple of minutes and complete that and provide your feedback for us. You will also receive, as I mentioned, a follow-up email within 24 to 48 hours that will include a link to the recording of today's webinar. Once again, Dr. Amore, thank you so much for your presentation and answering the questions. On behalf of the International Society of Fluorescent Guided Surgery, with grant funding from Diagnostic Green and our presenter, thank you so much for joining us, and please do all enjoy the rest of your day. Goodbye.
Goodbye. Thank you very much.